Okay, welcome back. Tonight we're going to do something a little different, different but the same. We're going to do an EKG review is what we're going to do today. Um, this will be in addition stuff. Some of you wanted to back up. I know these strips aren't the prettiest in the world, but you can see what you need to see, and we'll walk through these. These are also posted for you to practice in your course documents. We've also uploaded an ECG textbook and also a Hansen's anatomy reference, which is 400 pages of nothing but anatomy and physiology, all colorized and explained. Granted, a lot of it's at the physician level. However, paramedics learn a lot of stuff at the physician level, so much of that information is very much pertinent to what we need to do. For sake of argument, we're going to assume that these are 6-second strips. When you take your test, they'll actually be 6-second strips. When we look at 3-lead ECG, and I will do one of these recordings as well on 12 leads, when we look at 3-lead monitoring, we know that it's only used for determining heart rate and rhythm identification. 3-lead monitoring is not diagnostic. You can't tell a patient they're having a myocardial infarction. You can't tell a patient they're having a bundle branch block or anything else like that. But what it is good for is determining dysrhythmias and also, noting rhythms during resuscitation. So when we look at these, we know we have 3 pacemakers in our heart. We have our SA node, we have our AV node, and our Purkinje system. The SA node sits up in the right atrium. The AV node sits in the more downwind, and then the Purkinje system sits down in the ventricles. We know that 60 to 100 is intrinsic range for the SA node, 40 to 60 for the AV node, and 20 to 40 intrinsic rate for the Purkinje system. When we read an EKG, we wanted to note that each itty bitty box is 0.04 seconds or 1 millimeter in height. Remember, time is left to right because time marches on, and the other is amplitude or gain is up and down. So when we determine a rhythm, we want to look at several things. We want to look if it's regular or irregular. We want to determine if it's fast, slow, or normal. We want to note if there's a P wave present. If there's a P wave present, that tells us that this rhythm originates in the SA node, as long as the P waves are upright and regular. We want to look at our PR interval, which is measured from the beginning of the P to the R wave. And we also want to look at our QRS duration to determine how wide our QRS is. Normal PR interval is 0.12 to 0.20. The normal QRS duration is less than or right at 0.12. So when we have all these things, we know we have a sinus rhythm. If we have extra things, if the rhythm's irregular, then we need to figure out what those things are. So let's look at this top strip here. If you look on the screen, you see my pointer. We look at the rate. So 1, 2, 3, 4, 5, 6, 7. So roughly 8. So roughly the rate is 80. We can determine that it's an irregular rhythm. But if you look at the beats with P waves, they're all right in sync here. But we have this guy here, and this guy here, and this guy here, which have no P waves. Because they have no P waves and they're like narrow, we know those to be premature junctional contractions. Okay. We look at the underlying rhythm here. There's P waves are upright, and we know the underlying rhythm is a sinus rhythm. So this would be a sinus rhythm with premature junctional contractions. We look at the next one here, and we can see that this one here is bradycardic. It's got a rate of 50. We don't have a P wave before every beat per se, at least none of that are discernible as far as a PR interval goes. And we look at our ventricular rate, which is very regular, and we look at our atrial rate, which is very regular. So we know we have some form of a heart block because the P waves aren't correlating to the QRSs. And because there's no correlation between the P waves and QRSs, we have what they call atrioventricular dissociation or a complete heart block. The treatment of a complete heart block is based on hemodynamic stability and would involve transcutaneous pacing. Atropine is not indicated in a third-degree heart block or even second-degree type 2 as far as that goes. the problem is not something that's affected by the nervous system. The problem is something affected by a block in the cardiac conduction system. And that's why atropine, as a parasympathetic blocker or anticholinergic drug, will not work on a third-degree heart block. We look at this next one here, we'll see 1, 2. So we note the rate here is 60. We look, are there P waves? Well, yeah, there's P waves, but we have a period here that doesn't have anything. So we know the underlying rhythm, we have P waves, so we know that's starting off at least in the SA node. But we look here at our PR interval, here, 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 we can see that our PR interval elongates until we drop a beat right in there. Then we look at the second cycle, we can see that it's following suit. So whenever you have something like that, the PR interval elongates, so you drop a beat, we have a heart block, which is a second degree type 1 or your Winkin block, or also called a Mobitz 1. So second degree type 1, you drop 1. If we move on to the next one here, you'll note that it's bradycardic. We have 1, 2, 3, 4, 5 beats, so the rate's 50, but one beat doesn't look like the others right here. So we know that's an ectopic of some sort. So we'll look at the underlying rhythm. We know it to be a sinus rhythm. The P waves are upright, uniform, PR intervals within normal limits, 0.12 to 0.20, and the QRS is about 1 Bach, so definitely less than 0.12. So we know the underlying rhythm is a sinus rhythm, or it could be a sinus brady, however you say it is correct. This beat here is wide and aberrant, and it's greater than 0.12, so we know it's coming out of the Purkinje system, coming out of the ventricles, so we know that to be a unifocal PVC, or premature ventricular contraction. So this rhythm would be sinus bradycardia with a unifocal premature ventricular contraction. Okay. When we look at this strip here, we look at our rate, 1, 2, 3, 4, 5, 6, 7. Rate is 80. We don't see, it's very regular, we don't see any P waves. The QRS is less than 0.12. So a rhythm that has a narrow QRS that either has inverted or absence of a P wave is a junctional rhythm. We know junctional rhythms come out of the AV junction, which intrinsic rate is 40 to 60. So anything between 60 and 100 would be an accelerated junctional rhythm. So don't just use junctional rhythm, you have to go off the rate. A junctional escape rhythm or junctional rhythm is the same thing. Anything greater than 60 is accelerated junctional, and anything greater than 100 is junctional tach, and anything greater than 150 in this case would be supraventricular tachycardia or SVT. Okay. We look at this rhythm here, we'll see that this rhythm is very uniformed, and you'll see a sharp spike here. That sharp spike's not created by a human being. That sharp spike's being created by a pacemaker. And we see this as a total paced rhythm because every beat is identical in morphology and they all have that spike. Okay. Moving on, as we see here, this here is a very chaotic rhythm. If we look at it though, we will see some uniformity in it right here, here, here. So when we look at this, this here can be construed as ventricular fibrillation, but as we see, we do have distinct complexes. So whenever you have, and each complex is greater than 0.12, and as you notice, the points here turn. So what we have here is turning of the points, or torsades de points. It's a form of polymorphic ventricular tachycardia, and it's treated with magnesium sulfate, which is 1 to 2 grams IV. If this rhythm is not producing a palpable pulse, then it's treated identically to ventricular fibrillation and will immediately defibrillate this rhythm at either 200 joules monophasic or 200 joules, biphasic or 360 monophasic. We look here, we have a rhythm of 40, so we know a rate of 40, so we know this is a bradycardic rhythm. We don't see any P waves. QRS is less than 0.12, so we know this is coming out of the AV junction. And because this rate is 40, and the intrinsic rate of the AV node is 40 to 60, we know this to be a junctional rhythm. When you see here, we do see a lot of artifact in the baseline here, but we can generally see what we need to see. We notice the rate is regular, so rate's roughly 90. We can see P waves, okay? So we know this is a sinus rhythm with baseline artifact. And that type of artifact is also known as 60 cycle interference. So sinus rhythm with 60 cycle interference / it's a baseline artifact. You have a couple types of baseline artifact. You have 60 cycle interference. Electrical mechanical interference might be have your monitor sitting next to your suction machine while that's going. Also, you have patient movement artifact, which looks a lot different than this. It'd be EKG kind of going in a wave-like fashion. Let's say someone's breathing really heavy and fast. With the electrodes being the way they are, it'll cause the EKG tracing to move up and down. So this rhythm here, we know that it's very regular. Our rates 1, 2, 3, 4, 60. When we look at our P waves, the P waves upright and regular in front of every single beat. The PR interval is long, but it's the same for each beat, and the QRS is less than 0.12. So we know we have some form of a heart block because we denote all of our heart blocks by the PR interval, what it's doing. So we note this to be a first-degree heart block. You could say it's a sinus rhythm with a first-degree heart block. However, the most accurate depiction of it is a first-degree heart block. If we look here, we'll see this is bradycardic as well. The rate is 40. We do have P waves that are upright and uniform prior to every QRS. Our PR intervals within normal limits, 0.12 to 0.20. QRS is less than 0.12. So by looking at this, we see it as sinus bradycardia. Sinus bradycardia could be a normal variant for people that are super healthy, or it could be a result of a dysrhythmia. We base treatment on hemodynamic stability. Very rarely does sinus brady need to be treated. However, if they're unable to maintain good cardiac output and they're having some issues with it, you can consider giving atropine, which is an anticholinergic parasympathetic blocker medication, and that'll hopefully block that parasympathetic nervous system, allowing the intrinsic pacemakers to beat at their normal rates. However, if hemodynamically compromised, treatment of this would be sedation and transcutaneous pacing. And by sedation means you use some sort of a benzodiazepine, whether it be Ativan, which is lorazepam, Valium, which is diazepam, or Versed, which is midazolam. So whichever one you choose to use. This one here is a baseline, or known as the isoelectric line. However, it's hooked up to a patient. It's known as asystole, which is the absence of any cardiac activity. We always want to check this in 2 or more leads to make sure and rule out fine ventricular fibrillation. If we do suspect fine ventricular fibrillation, then we defibrillate it. However, this is very, very flat and is more indicative of asystole versus anything else. Excuse me. If we look here, we have a rate of roughly 120. As we see here, we don't have any P wave at all. We have no PR interval. So what we're seeing here is a junctional rhythm, and junctional rhythms are normally 40 to 60. 60 to 100 is accelerated junctional, and greater than 100 and less than 150 is junctional tach. So that's what we're looking at there, is a junctional tachycardia. Okay. Don't be too confused by this little bump right there and there. What you're actually seeing there is the Q wave. So it's going down, Q, R, S, and there's your ST segment. So don't get too mixed up thinking that's P waves. Always look at the whole rhythm in and of itself and denote each part of the rhythm. As we see here, we know we have a big chunk of missing stuff here. We note that we have 1, 2, 3, 4, 5. So we have a rate of 50. It is profoundly irregular. However, our PR intervals beat to beat match. So we know this is some form of a heart block. So we have more P waves than QRSs. So that makes this a second degree type 2 or secondary type 2, Mobitz 2, or classical heart block. And this here would be considered either a 2-to-1 block because there's 2 P waves, 1 QRS, or a 3-to-1 block, 1, 2, 3 to 1. So, but important to remember secondary type 2. Your PR intervals will be regular every perfusing beat. Okay, right here we know that our rhythm is fast. We note the QRSs are fat, they're greater than 0.12. There's no P wave, so we know this to be ventricular tachycardia. And because they all look the same, it's a monomorphic ventricular tachycardia versus polymorphic ventricular tachycardia. So this here is VTach. The treatment for VTach, if they have no pulse, is the same as ventricular fibrillation, immediately defibrillate. If they're hemodynamically stable, we can give them a ventricular antidysrhythmic, whether it be amiodarone, which would be 150 milligrams in your conscious alert patient, or 300 milligrams in your cardiac arrest patient. Your second dose in cardiac arrest would be 150, and your second dose in VTach with a pulse would be 300. So your dose is just kind of opposite of each other. You can also give lidocaine, which is 0.5 milligrams per kilogram to 1.5 milligrams per kilogram, with a max dose of 3 milligrams per kilogram, followed by a 2 to 4 milligram a minute infusion as long as the ectopy has been suppressed. So we went through the lidocaine clock in class, how to calculate that. Lidocaine is administered on a 60-drop set, which is a med administration set, and we run it 2 to 4 milligrams a minute. Next rhythm here, we see some, it looks kind of chaotic and kind of goofy here, but these rhythms are wide and aberrant, but see how they're changing directions. So we're seeing polymorphic VTach or torsades de pointes again. And treatment is magnesium sulfate, 1 to 2 grams is normally what fixes this. If it's pulseless, obviously you're going to treat like VFib or pulseless VTach. Right here, we see some significant artifact. We can see with P waves, we see our rhythms regular except for this one beat there, which we can see a P wave before that beat there. So we know this is a sinus rhythm. Okay, and with baseline artifact, and this here, because it is earlier than the rest of them and has a P wave, is a premature atrial contraction. So it'd be a sinus rhythm with a premature atrial contraction and baseline artifact. And this here would be 60 cycle baseline artifact. Okay. When we look here at the next one, we see 1, 2, 3, 4, 5, 6. You count the one at the end. It's irregular. It's irregularly irregular, meaning that none of the R to R's match. We look at the baseline here. We see the baseline is fibrillating. So we know this is atrial fibrillation, which is irregularly irregular and has a fibrillating baseline. Atrial fib is treated based on rate and symptomology. Generally, we don't need to treat AFib much in the field, but our concern with this is whether it's new or old. A new onset atrial fib, those patients need to be anticoagulated. And also, we also need to be cognizant to the high risk of CVA or cerebral vascular accidents associated with clots thrown from atrial fibrillation, leading to a thrombus in the brain. So the brain's vasculature, actually. Okay, if we look here, we'll see that the rate is very fast. Okay, we don't see any P wave per se. So depending on what the rate is, we can call it a supraventricular tachycardia if it's greater than 150. And remember, if we assume this to be junctional, if the rate's greater than 150, that still becomes a supraventricular tachycardia as well. When we look at this, and the treatment for supraventricular tachycardia is Adenocard, as long as it's regular. Dose on Adenocard is 6 milligrams, followed by a second dose of 12 milligrams. It used to be recommended to give a third dose of 12. However, American Heart Foundation has shied away from that, and we give a dose of 6 and a dose of 12. And if that doesn't work, then we'll go to synchronized cardioversion with this. Remember, cardioversion has to be synchronized. If it's non-synchronized, then all you're doing is defibrillating, which could throw the patient into VFib or VTAC because of RNT phenomenon. Okay, if we look at this one here, we'll see of all the rhythms I told you guys never to memorize what they look like, except for this one. We see the sawtooth pattern here. The only thing that produces that sawtooth pattern is atrial flutter. So up in the atria, it's fluttering, not fibrillating. So it's opening and closing, and that's just giving you this flutter wave, which is atrial flutter. Generally, our treatment for atrial flutter is based on symptomology and hemodynamic stability. Atrial fib, atrial flutter with a rapid ventricular response can be effectively treated with cardizem or diltiazem at 20 milligrams given over 2 minutes, or any other calcium channel blocker as far as that goes. Verapamil is a drug that is still carried in some areas, which is a calcium channel blocker as well. But we carry cardizem or diltiazem in our system, and 20 milligrams over 2 minutes for rate control is generally recommended. This here, we notice that the rate is 40, so it's a bradycardic rhythm. It's wide, there's no P wave, so we know this to be an idioventricular rhythm. You could technically call it a ventricular rhythm, however, the correct terminology is idioventricular rhythm. It's coming 100% out of the Purkinje system, and your rate is 40, which we know the intrinsic rate of the Purkinje system is 20 to 40. When we look at this rhythm here, we notice that everything looks the same pretty much except for this guy, and that guy. So we notice there's P waves before every one. They're upright and regular in front of every beat. When we look at this oddball beat here, we notice there's no P wave there, there's no P wave there, and there's no P wave there as well as there. So we do know that because the QRS is less than 0.12, there's no P wave. We know this to be an accelerated, we know this to be a sinus rhythm with premature junctional contractions. So sinus rhythm, premature junctional contractions. Okay. The next one here, what we're seeing here is, what's our rate? Rate is 130, 140. And as we notice, our R waves get a little bit narrower there versus here. But it's all, it's for most part regular. And what you're seeing up to this point at least is a sinus rhythm. And what you're seeing is this patient is getting a change of rhythm going from a sinus rhythm into what will end up being a sinus tachycardia, because these all have P waves and they're upright uniformed and the rate is picking up compared to that. Don't confuse that with like a sinus dysrhythmia or sinus arrhythmia where it's a sinus rhythm but it's irregular. You do need to know rate changes, so you want to run a longer strip and look at that. And remember, sinus dysrhythmia / sinus arrhythmia is normally seen in pediatric populations or elderly populations, and it's where the intrathoracic pressure is changed on breathing, causing increased pressure on the heart, causing decreased cardiac output. So the heart rate will slow and pick up and slow and pick up. So we see this here as a sinus rhythm with a change of rate. Here what we're looking at, we see a lot of this aberrant stuff. We have a set here, and a set here. But we always look for the ones with the P waves first. We have a beat here and a beat there with P waves. They're uniform. So we know these are sinus beats. And we know that rate of the SA node is 60 to 100. Less than 60 is a bradycardic rhythm. So we have a sinus brady. These all look the same. They're wide and aberrant, so they're coming out of the ventricles. And these two look just like these two, which looks like these two. So this would be sinus bradycardia with couplet PVCs. If you want to go as far as saying sinus brady with unifocal couplet PVCs, then that's appropriate as well. But generally, a sinus bradycardia with couplet PVCs is the appropriate statement. Okay. If we look here, we'll see that this rhythm here is irregular because we got extra stuff. We have an extra beat here, have an extra beat there, and an extra beat there. So we look at the P waves. Pure intervals there is fine, it's there fine. All normal limits, QRS less than 0.12. So we know the underlying rhythm is a sinus rhythm, not a normal sinus rhythm because there's abnormality in it, but a sinus rhythm. We look at the ectopics, we'll see there's a P wave, your QRS, ST segment, and these all look the same. So this would be a sinus rhythm with premature atrial contractions. And we know these be premature atrial because of a P wave, and P waves come out of the SA node. So we know it's a sinus rhythm with premature atrial contractions. This next one here that we're seeing is rate of 60. Everything looks relatively normal. PR intervals are normal limits, less than 0.12 to 0.20, less than 0.12 for a QRS duration. We have this beat here, which is wide and aberrant. So we know this is a ventricular beat. So this here would be a sinus Brady with a unifocal PVC. Okay. This one here, we see 1, 2, 3, 4, 5, 6, 7, so roughly 70 or 80. We have P waves are upright uniform, pure intervals within normal limits, as well as the QRS being less than 0.12. So we know this to be a normal sinus rhythm. And it's the only rhythm that can be normal sinus rhythm. Anything that has abnormality cannot be normal. It might be normal for that person, but it's not delineated as a normal rhythm. Normal sinus rhythm is the only rhythm that is normal. We look here, we see the rhythm here. It looks regular except for all this extra stuff, so it's definitely irregular rhythm. We look at the rhythm ones with the P waves, we see that's the sinus Brady. We have a rate of 30. And we look at these don't look the same. This one looks similar to that one, and that one definitely looks different, but all of them are greater than 0.12 and they're wide and aberrant. So we know they're premature ventricular contractions. And because they look differently, they'd be called polymorphic. Actually, excuse me, I'm sorry, multifocal premature ventricular contractions because they definitely look different. And if you want to delineate it further as far as here, as far as looking here and here, you do have a P wave every other beat there. So you can say multifocal bigeminal PVCs, at least right here. But you really want to run a longer strip to see if that trends out. Right here, our rate is 1, 2, 3, 4, 5, 6. Rate is 60. They're wide and aberrant. So we know this is coming out of the ventricles. So we have an idioventricular rhythm, which is 20 to 40. And this here would be an accelerated idioventricular rhythm, which will go up to 100. Anything over 100 would be ventricular tachycardia. This rhythm here we know is fast. It's greater than 150. However, we could make out P waves in front of every single one. So we know this to be based on patient presentation. We'd want to look for things like dehydration, things of low perfusion states, low blood pressure, whatnot. This here is more than likely a sinus tach, which can exceed 150 with profound dehydration due to catecholamine being released from a low pressure state, being low volume. If they're hemodynamically stable, no sign of dehydration, then we want to consider possible causes, and this could very well be treated as a supraventricular tachycardia with adenocard if that is indeed the case. However, with this being a sinus tach, you want to definitely treat it with a fluid bolus first and see if the rate resolves. And standard bolus is 20 mLs per kilo. I know this was kind of a fast and easy ECG review, but we covered most of the rhythms in general. If you're still having EKG problems after this, we do have other packets of strips listed. I will be doing a 12-lead review as well. However, your final exam will be solely over trauma, is what your final exam will be. So feel free, like I said, everyone, ask questions, send me text. I'm doing it on the Facebook page, however you need to get it done. But give me questions. I'll be glad to answer anyone. If you have any confusions, comments, concerns, things like that, just let me know. You guys have a good day.